Our first question to the panel, we have a esteemed panel here, is one of the talks was about handling patients that have had previous refractive error, maybe a little regular astigmatism. I'm just curious how you guys are handling these patients, to help either prevent from being off target or if they are off target. I know they talked about the IC8. I know Ashwin may have some other tools in his toolbox. There's adjustable IOLs. There's corneal enhancements. Just curious. I don't know who wants to start.
So, I mean, IC8 is a great option, but unfortunately, it's not easily available all across the world. And something that Dr. Amar started doing was pinhole pupilloplasty, basically making the pupil small enough to make the pupil behave like the IC8 to do what it was doing. But there are certain advantages to making the pupil smaller and rounder. IC8 goes behind the concept of making the pupil small, but pinhole pupilloplasty does is customizing that for that patient. What that means is the chord mu actually reduces, but you have to center that chord mu to that patient's need. And that is possible if you can drop the pupil size, customizing that pupil size, centering it to that patient. And that's certain advantages that Jack Holliday actually explained. And that really brought in a lot of light when we started doing this procedure. And we are still mastering this day in, day out. And this is a big tool in our armamentarium. Patient comes up with huge amount of -8, -6 astigmatism. And the next day post-op, he goes back with 20, 40, 20, 30 unaided. Which is remarkable change in the 1 day post-op with a pinhole pupilloplasty. So basically making that pupil 1.5 millimeters is the key, and keeping it tight to that first Purkinje image. And those are the certain key points I would say. Anybody wants to have a chat offline, we can definitely take that offline.
Thank you.
Ashwin, how do you address the issue of looking at the retina in these patients? Because there are issues that arise over time.
Yeah, so it's a great point. I think a couple of factors over here that really helped is changing the pupilloplasty technique. The single pass 4-throw pupilloplasty is one technique that has the least amount of manipulation and trauma to the iris. So the left has dilatation. You can still dilate that pupil out a little bit more. Yes, the central view of is definitely available even if you drop the pupil size and your this thing, but the periphery definitely does. You can be faced with a little bit of a challenge when it comes to the periphery.
Perfect.
I'm sure that. Yep.
No, beautiful. No, it's such a great description. I just have Eileen comment on your handling patients with previous refractive error that undergo cataract surgery. Are you considering like the light adjustable lens or some of these technologies, or what's your go-to?
Usually, I am correcting after, for example, multifocal lens implantation. There is refractive error. I'm correcting by using LASIK surgery. This is also not all cases. We have to preoperatively we have to evaluate very carefully, because autorefractometer usually giving mistake. We have to be very sure about manifest refraction. And wavefront measurements also not very useful when we are correcting after postoperative residual astigmatism, diffractive surface, and we shouldn't use wavefront measurements, wavefront guided treatment.
I make my best shot at whatever lens I think I need to put in the patient. So I'll do the measurements in the cornea. I'll see whether they need a toric lens or not, and I'll use the zero aspheric IOL. I'll do my best shot and see where I get with that. If I still have issues following that, I will use the moisture sulcus implant with the pinhole, because I think that's very effective. But I'll use that as a secondary procedure. It's very nice to put into the sulcus, and you can image through that implant.
Burkhard, what about yourself?
But if it's really irregular, I mean, that means highly irregular, that the extra focus works very well from Morcha, as George already said. Then another point is that especially preoperative counseling, informing the patient, as Scott already pointed out, is so mandatory in this, because there may be an additional procedure. But I like personally to fix the problem intraoperatively. That is the IC8, and the Australian results were very impressive. This is real world data. on the gross scale. And then, of course, the light adjustable lens technology fixes to 3 diopter, but not irregular astigmatism, regular cornea.
No, beautiful. Perfect. So I think should we? Thank you very much.
In time.
We'll go in the next session. Thank you.
Thank you.
Great job.
Thank you.